Thank you very much for your help with the recovery trial to date. This brief presentation just explains the rationale for the second randomization in the recovery trial and how it is done. So the second randomization is testing a drug called Tocilizumab. And Tocilizumab is a drug, a monoclonal antibody, which blocks interleukin-6. So I'm going to start just by explaining the normal role of interleukin-6, which you can see here on the left-hand side of the slide in the blue boxes. Interleukin-6 is released during inflammation into the bloodstream, and it's a messenger that travels around the body and can bind either to its receptor on the surface of other cells, or it can bind its receptor in the bloodstream, its soluble receptor. But once bound to its receptor, the interleukin-6 and its receptor then binds to a second protein called GP130 on the cell surface, which in turn activates an intracellular pathway called the JAK-STAT pathway, which leads at the bottom of the slide to inflammatory processes such as CRP production and B and T cell stimulation. When a patient is given tocilizumab, the tocilizumab binds to the receptors instead of interleukin-6, so it binds receptors on the surface of cells and in the bloodstream, preventing interleukin-6 from binding. And because it does that, it then prevents interleukin-6 from activating the JAK-STAT pathway, and you get less inflammation. So that is why tocilizumab is currently licensed for conditions in which there is too much inflammation, such as rheumatoid arthritis, or a rarer condition called the cytokine release syndrome, which occurs after a new form of treatment for some hematological malignancies. The interesting thing about the cytokine release syndrome is it's very similar to the clinical picture you see in some patients after they have had COVID for 7 to 10 days and they suddenly deteriorate. Tocilizumab is also being tested not only in recovery, but in 2 other trials going on in the UK called REMAP-CAP in intensive care and COVACTA. So this is the trial design that you're used to seeing, where patients are randomized after they're admitted to hospital with COVID between 1 of 5 treatments, and the outcomes, as you already know. So the second randomization might make this look a bit complicated, but it's not so bad. So patients are recruited into the trial in the normal way and get allocated to one of their 5 arms in the main trial. And then if they meet certain eligibility criteria, which I will explain in a minute, they can then be re-randomized between continuing on their treatment from the first randomization, but get re-randomized between receiving tocilizumab or control. And then the trial will produce another answer comparing tocilizumab versus control using the same outcomes as from the first randomization. So it's important to remember that patients both get the original drug and they continue on that, and then they either get tocilizumab or control added on top. This randomization won't be conducted at all sites due to a limited drug supply, but we do have enough drug to randomize about 4,000 people. The randomization can be done at any time from immediately after the first randomization until 21 days later. And consent for this randomization is included in consent into the main trial, and you'll see that described in the latest version of the information sheet, version 4.1. Participants who are in the trial with a previous version of the information sheet can be included in this randomization if they're still in hospital and meet the criteria without having to be reconsented. So the eligibility criteria for this second randomization, apart from already being in the trial, having been randomized into the first randomization, they also need to either be receiving oxygen therapy, or if they're not on oxygen, to have saturations less than 92% on air. They need to have a CRP at least 75 milligrams per litre, and there needs to be no medical history that might, in the opinion of the attending doctor, put the patient at significant risk if he or she were to participate in this aspect of the recovery trial. And examples here might be clear evidence of a secondary bacterial infection being the cause of the deterioration, or already receiving drugs which block interleukin-6, for example, already being on another interleukin-6 receptor antagonist. So the second randomization is accessed in one of 2 ways. It can be access for any patient who's already in the trial through the main randomisation system, and you'll see when you log into that from the 23rd of April onwards a new option which is highlighted on this screen to enrol patient into the second phase. Alternatively, if when you've entered a patient into the trial in the first phase and they've been allocated their drug, as you can see this screen shows the usual drug allocation page, you'll see there is now highlighted at the bottom a new button to randomise into phase 2, so you can directly then put these participants straight into the second randomisation. Whichever option you take, you will come to this page where we collect some simple data about the patients. So we want you to enter their date of birth as a form of positive patient ID, the name of the treating clinician. Question A3 asks whether the patient requires oxygen, a simple yes/no, and if yes, you'll be asked to describe if they are on any sort of ventilation, and if so, what sort, and enter their latest oxygen saturation measurement. The next three questions, A6 to A8, ask for their most recent blood results for CRP, ferritin if it's been measured, and creatinine if it's been measured. You can simply indicate by ticking if they have not been measured, or in the case of CRP and ferritin, some laboratories may say these are simply greater than the upper limit of normal, in which case you can tick the box greater than limit of measurement. Question A9 confirms that there is no medical history that would suggest that the patient should not be re-randomised, and question A10 confirms again that whether the treatment is suitable or not for the patient. Remember, question A10.1 is asking, is the following treatment unsuitable? So if you need to answer that no to randomise the patient. And we need you to confirm that you have Tocilizumab available. And then you enter your name and email address as usual to sign off. If the patient is eligible for the trial, then they are assigned to the drug or to control. If they get the Tocilizumab, then dosing is weight-based, but unlike other trials of Tocilizumab, we are using some broad weight-based bands to make this simple. So it's either 400, 600 or 800 milligrams, depending on the weight of the patient. If you cannot weigh the patient, it's possible to use their estimated weight. If their weight is below 40 kilograms, it will be necessary to weigh them, and the dose will be 8 milligrams per kilogram. And this can be given as a single intravenous infusion over 1 hour in 100 ml of 0.9% sodium chloride. The protocol does allow for a second dose to be given between 12 and 24 hours later if, in the clinician's opinion, the patient's condition has not improved. But it is only one further dose. So in recovery, the maximum number of doses is 2. Tocilizumab is ordered in the usual way for the other IMPs in the recovery trial through Informs and Movianto, and we will be in touch with you when that is available to you. Sites will be able to order enough for 20 patients in the first instance, but please do get in touch with us once your stocks are reducing, in particular when you think you have treated 10 patients, and we will also be monitoring this. Further information about Tocilizumab, including the intervention sheet, which has further details about the drugs, is available on the usual trial website. But thank you very much for your help and for your attention.